Hello, everyone, and welcome to the Pharm podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the podcast. This is Aebhric O'Kelly. This week, we are again joined by Eirik Holmstrom, who is the director of our CPD programs at the college and has been on our faculty for almost a decade now. Eirik, welcome back to the program.
Thank you, Aebhric. It's good to be back again.
So, Eirik, tell the listeners what exactly you do for Pharm.
So basically, I'm supervising and organizing the CPD courses, the online courses at our website. So I follow up students who have any questions or any technical issues and try to sort that out. And I also manage all the practical courses at our location in Malta, registering the students when I get them from the registrar and make sure that they get the information that they need to join us down in Malta, and making all the planning and preparation for the courses for the bachelor students, the master students, and also for the CPD students who want to do a practical training in Malta.
So part of that is you run the online CPD programs, which is the MIC, MEC, and Pharm was the first three. They were the first three that we started. We've had more online programs join the first three, but today we're going to talk about the MIC, the minor illness course, MEC, the minor emergencies course, and the Pharm, which is pharmacology for the remote medics. And Eirik, you and I have just upgraded them. We did a complete rewrite, redesign audit of what we had before, and we've updated it, and now it's launching.
Yeah, as you said, Aebhric, these first courses, I think they were started about 10, 12 years ago, where we put them on, and they were actually quite well appreciated by the students, and they've been upgraded sometimes according to new protocol, new routines, and new treatments. But now we actually have taken those three courses and totally renewed them. And we're also putting them on a new platform that has more potential. And I think that the launch that I think we're going to have on Monday next week is going to be awesome. And the students who want to look into them will see that this is a total renewal of those three programs.
Yeah, so they go together. We created these as a package deal, focusing on disease and non-battle injuries, what we called it in the military, but I think minor illness, minor emergencies, primary care, general practice, that kind of stuff. And there's tons of other CPD online programs out there that focus on minor emergencies, minor illnesses, and pharmacology. But we did something, well, we always do something different. We focused on the remote medic. So drawing on a lot of your background, Eirik, in special ops, as well as teaching in the NSOCM course. So you were running the curriculum for the NSOCM course for a while. What DNBI topics were you teaching in Pfullendorf, Germany?
Well, basically, the SOCM course was built on, it's basically mostly trauma medicine and prolonged field care. But we also implemented these three topics, that the minor illness and the minor emergency and the pharmacology. Because when we're talking a lot about trauma today, and that's understandable because the world is a more dangerous place and we have more wars going on than we had before. So we mustn't lose focus on the normal things that EMTs in the austere environment can actually incur. And that was also one of the points in the SOCM course, because the soldier has to take care of themselves when they are in a fob or on patrol. And it could happen that they have illnesses or they have minor emergency like ankle sprains or toothaches or whatever you have. And one of the other things that's important that we focus a lot on the NSOCM is the pharmacology module, because what we know is that pharmacology is something that people struggle with. We've seen that on several of our practical courses, especially when it comes to calculation. And I think that knowing more about pharmacology, knowing more about minor emergency that is not directly a trauma, and also about illnesses like diseases like fever, like headache, and all these things that doesn't necessarily need commitment into the hospitals. I think that's as a thing that all austere and remote paramedics should know about.
That was the original reason that Pharm was invited into the NATO Special Operations Combat Medic course because we brought in this disease and non-battle injury type thing. So we designed and ran the TropMed Week, which included all sorts of illnesses and minor emergencies, as well as pharmacology to cover that. There was very little trauma in that week. And I think NSOCM is still running the curriculum we created to bring in a bit of the DNBI. So for those of you who don't know what DNBI is disease and non-battle injury. It's an Army term that someone came up with ages ago because throughout history, more people in a military and a military conflict died from diseases and non-battle injuries than ever died from combat. It wasn't until we got the hand washing sorted with Semmelweis in 1864, 1865, that we found that for the first time in history, fewer combatants were dying from non-trauma. As World War I was the big testing ground for this new concept of preventative care. And then now, 150 years later, we are doing very well with DNBI, but we still, because who we are, we're SF mentality, you and I, and we just love trauma. And we still have to realize the majority of the things that we see on an operational setting is not trauma.
Yeah, because that's what when you guys come down to Fullendorf to help us out with that and had the topics of tropical diseases, I was thinking about, okay, tropical diseases, that's just a small portion, especially for me coming from Norway. We don't have a lot of tropical diseases. We are focused more on hypothermia and those kinds of things. But what I learned from you guys, and that's also the reason why I went to London School of Tropical and Hygiene to do the course there, because it's not only, so tropical diseases is actually minor illnesses course also, because a lot of the tropical diseases will put people out of operation if they cannot mitigate or they cannot prepare for that. So when you taught that the tropical portion of the SOCOM course, I learned a lot about minor emergencies and also minor illnesses, and also a lot of pharmacology, because that goes also into pharmacology. What kind of drugs do I need if I go to a tropical area? I need to know more about those. And that's why I thought that this MIM, MEC, and Pharm modules that we have created is actually a great add-on to people who's working in austere environments.
I'm glad you mentioned the DTN program, the Diploma of Tropical Nursing from London School of Hygiene and Tropical Medicine, and Liverpool has one as well. So every medic should have this. If you're a military medic, operational medic, paramedic, or nurse, go get your DTN, because it covers these in such an extreme detail that it made me a better medic.
Absolutely. I second that one, because I learned a lot when I went to the DTN. And also it made me think much about more preventive medicine and how we can avoid, and this is what this course also covers, is how can we prepare for tropical deployments? How can we make sure that we have the right vaccination? How can we prepare the camps? The easiest thing to think about is, what about our sanitary problems in austere environment? We had an incident in a deployment to Afghanistan with the Norwegian. We put up a new camp in Mazar-e Sharif, and we didn't prep good enough. So we got a lot of diseases because the ground was full of rats and snakes and whatever you have. So we had to actually excavate all the grounds, do it again. So in this camp, we had a big outbreak of leishmaniasis, because, or not a big, but we got some soldiers who was bitten by this little sandfly. So we learned how to prevent ourselves for this. And also we had a big outbreak now because of hand sanitation in the kitchen. We had 100 people in the hospitalized because of dehydration. So we also had a lot of people. Actually, we had 100 people, I think it was, in beds having the shitter and diarrhea, because we found out that on the kitchen staff didn't wash their hands good enough, so it infected the entire camp. And we had 100 people in bed in a tent that we had to put IV fluids on everybody, and they were not feeling happy. So this is things that these courses also cover.
Yeah, we hit diarrhea quite heavily. It's one of the 5 MADAT diseases, the top 5 tropical diseases that will affect casualty. We spend a lot of time on our field guide about that, and hydration ladder. I just published something on LinkedIn about the hydration ladder to keep someone from dying of this disease that you had.
Yeah, and also talking about the minor emergency course. In my years, I have 30, 40 years in the pre-hospital space now. And what I see in the civilian ambulances in the austere environment is we don't have a lot of trauma, or we have minor trauma that can be fixed without sending the patient to the hospital. And I think that the MEC is absolutely perfect for people who want to learn more about ankle sprain, how to fix toothaches, how to fix headaches, and things that is not necessarily that you have to send the people to a hospital, but they can still do the mission, or if in a civilian life, they can still do their work in the mountains.
I remember when I was in 3rd Special Forces Group in 94, we invaded Haiti and spent 6 lovely months there. Every medevac, every one of them, was a minor musculoskeletal, like a twisted ankle. We never had a trauma in that 6 months. It was always, oh, here comes the helicopter again. What happened this time? Sprained knee or eye injury or something like that. So we need to learn these basics well. I mean, what makes Special Forces special? I get asked that. And my answer is, we know the basics well. And MIC and Pharm are the basics.
Absolutely. This is the basic that we are more prone to incur in the daily life when we are working in austere environment, and also in cities, because people are falling over, and we need to know how to treat them and not go totally overboard and treat them like a trauma case, even because a lot of these people have a lot of pain, and we think maybe that this is a major trauma, but is absolutely something that we can take care of there and then, instead of rushing them into a hospital.
So when reviewing the MIC and Pharm, we had 10 years of feedback from people who've gone through the program. And with the minor illness course, we removed a couple of items that people found that they weren't applicable, and we updated everything else. And we added some in, because based on the student feedback on how using the student feedback is how we improve any course in the college, but it's the same for this one. So I really enjoyed going through each of these with a fine-tooth comb and upgraded them and enhanced them and added more up-to-date protocols. So the MIC is focusing on illnesses, and the MEC is focusing on minor injuries. And I've broken the MIC, the minor illness course, down into systems. So respiratory system, cardiovascular system, nervous system, gastrointestinal, gastrourinary, skin, and then eye. And I did the field guide at the same headings. And in our quorum field guide is a profound amount of DNBI that is found here. So with the illness course, looking at all the respiratory problems, hay fever, COPD, pneumonia, upper respiratory tract infection. For the cardiovascular, what we looked at was angina, which is cardiac induced, but we also looked at musculoskeletal problems that you can have. I'm an old guy. I've got lots and lots of arthritis from carrying a heavy backpack. I get chest pains that are musculoskeletal. So it differentiates between angina and musculoskeletal. And with the nervous system, we talk about headaches, dizziness, insomnia, motion sickness. People forget about motion sickness. They bring up all these heavy hitters like ketamine and stuff, but they don't bring meclizine or something that will help with motion sickness. And GI, we all need to worry about GI problems, because we get deli belly, or bacteria in our GI tract isn't quite used to the food down in Kilimanjaro. So you might have a bit of a week or two to get used to the food. So having that in there. And in skin, I mean, tropical dermatology is a whole master's program, but we do discuss some of the dermatological problems that a remote medic would see.
Sorry, no, because I'm just sitting and looking at the program now, and we cover almost everything that can occur on a basic level. Because, as you said, to go into details on tropical medicine, then you should do the DTN. I mean, but it's like it covers everything. It covers, for example, it covers skin diseases, it has dry skin and fungus. how to treat funguses, nail infections, how to treat warts, scabies, sunburn, all these things that we really need to know when we are good medics in austere environment, because we can be 3-4 days without getting the patient or the proper treatment at the hospital. We need to know what to carry in the different situation or the different deployment or places that we're working.
Yeah, indeed. So 10 years ago, I created the curriculum for the MIC and Pharm. And what I did is I looked at the Wilderness Medical Society and I looked at the JTS and other published research to see what were the top 20 injuries, non-trauma injuries, what were the top 20 illnesses seen on expeditions, and then what were the top 20 drugs that were used on expeditions. And that was the basis for this. And we've developed it since.
Yeah, and I think going through this and the way you put it up with the MIM and the MEC and also putting the Pharm into this is absolutely a great package for a medic who is going to work alone in an austere environment. Because if you go through these courses, I think that you will have a good overview and you will probably also be more interested in going further on and see that this is a lot of things that's not covered in the basic EMT or the basic self-medic courses normally.
Yeah. So I've used these three to cover a lot of the primary care. And what I'm doing with this relaunch is we're combining all three of these into a package. Now you can still get these individually because people might want to just get the MEC and not the MIC and the Pharm, but we're going to have something called the APC. It's the Austere Primary Care Package. And with that is the MEC and Pharm. I'm going to throw in some Wazoo lectures from around the college as well to iron out a bit more in depth than what the MEC and Pharm does. So I have lectures that I've done for the Masters of Austere Critical Care. I've got lectures that I've done for the remote paramedic program that includes like water procurement and things like that. And I'm going to put all of this into one package so you, with just one click, can purchase the APC, the Austere Primary Care, and get the MIC and Pharm along with the Aebric's top 10 lectures that I've come up with over the last 10 years.
Yeah, and the thing is that I'm actually looking through it now, and I have to say it's a great update. It gives me a lot of new things also that I need to know more about, even though I've been studying this for 30, 40 years. But actually, in a couple of weeks, I'm going up to the north of Norway, teaching for what we in Norway call the Role 1 medics. As you probably know, in Norway, we have the conscription. So people are going into service for 1 year. And there's selected, I think it's about 50 people who's going to be supporting the nurses and the doctors in the role ones in the camps. And I'm throwing in a lot of these lectures or trying to use a lot of these lectures and backgrounds to teach these guys how to treat, because basically they're not treating trauma. They are treating people. They are alone at the night and they have to have the knowledge on how to treat these diseases and these minor illnesses when they are alone at the role 1 without calling the nurses and the doctors. And I'm going to give them these courses so they can actually learn more about these DMI or DNI. What did you call it?
DMI is Deployed Medicine International. That's the John Hagman, which was you and I first met at a John Hagman DMI course in 14, I think it was.
Yeah, it's about DNBI. I'm going to actually talk to you later on how we can implement this, or I can try to implement this for the role 1 conscripts working as medics without any former background, but they're going to assist the doctors and the nurses in the Norwegian role 1 in the camps around in Norway.
And it made me think, like, we can put this in Norwegian, but all you guys speak English anyway, but we should look at translating this into Ukrainian and giving this free of charge to anyone on the front lines.
Absolutely, because as we've been teaching trauma in Ukraine now for a couple of years, I think you and I went down there the first time to teach the damage control resuscitation for Ukraine frontline medics 2 years ago, I think it was, last summer, 2 years ago. And we also should maybe start to focusing on these kinds of DNBI lectures and put up a course for them. We're actually getting the people to Malta to get some more hands-on skills for trauma. But I think this DNBI also is something that we should focus on. data.
Yeah, indeed. And I mean, we need to focus on the Hitman sheep vomit for the guys in the front lines and getting the tourniquets downgraded and getting the infections sorted. But eventually, when they're not dealing with trauma, they're going to need austere primary care.
Yeah, and I actually think they need a little bit or knowledge about it now, because as we know, there will take maybe days to get people out they're getting out on the front line and they are in a stab point or a stabilization point. And we have diseases and illnesses. As you know, people are not the young ones always. It could be the old ones, and they need to know more about normal diseases like heart problems, like respiratory problems. And respiratory problems is also something that they have quite a lot of in Ukraine also, and also in other places that we are now involved in conflicts.
But I'm glad you brought that up, because if you look at tuberculosis, it's rampant on the other side, but it's also rampant. I mean, there's too much TB in the front lines of Ukraine, and they can't be blamed, in all fairness, because they're working in really difficult environments and it's cold. So you're going to have everyone that you can into one enclosed area. So TB is a problem. I think they're handling it better than the other guys, thankfully. Yeah, that's a DNBI issue, isn't it?
Yeah, absolutely. And we also see that in Norway, because the conflicts are actually making more people, well, we get a big refugee situation around the world now, and people are coming from areas where TBI is a big issue, and they are coming to places like Norway where we actually didn't have it, but now we see an increased number of people with it.
That's true. I hadn't thought about that. The migration is bringing these respiratory issues with them.
Yeah, and also the tropical diseases.
As a trop med, I guess I can't actually have a discussion anywhere without bringing up trop med, and you're a DTN graduate as well. So it's interesting to see the minor illness course should cover tropical diseases, because we're seeing local transmission of tropical diseases in mainland Europe and also in Florida and Texas. And it's just a matter of time before I think everyone's going to need a MIC course, because of global warming is pushing these diseases north.
Yeah, absolutely. And to quote our good friend Jason Jarvis, fever without any known origin, or you don't know what causes the fever, it's malaria. And that's not true for Norway, basically. But what I learned, I also work as a paramedic for a community health service, driving doctors to patients who can't come to the doctor's office. And what I learned the doctors now the last years is that if they have a fever and there's no elevation in the infection measuring the CRP, then we should ask the patient, have you been traveled? Have you been to Africa? And I had actually one patient with a fever who just 2 weeks ago came from Africa.
This is why we have the R in sampler. R is recent travel.
Yep. And I think we need to think more about that in the coming years, that people are more mobile. We have refugees, we have people flying all over, and they've been on holidays in places where there are different infections and different diseases that we are normally used to see in other countries.
So one more reason to take the MIC and Pharm.
Absolutely.
So as we move forward, as we do the official launch of and the rebranding of the MIC and Pharm into the APC, the Austere Primary Care, we are going to need to add a bit of trop med there as well, and we will, because it is a DNBI issue, tropical diseases. But we are focusing these for the remote medic. And when we say remote medic, we're talking about, well, we have graduates who are doing the offshore industry, such as wind farms or oil rigs or on expeditions. We have people go on humanitarian missions and remote sites, and of course, soft medics. We have quite a few graduates and people going through our programs who are soft or soft support. And this is what we design these for, is for those of you working in remote, austere, and resource-limited environments. Well, the whole nonprofit I founded Quorum with the whole concept of we need to bring academic backing for all these all these medics working in difficult environments.
Yeah, absolutely. I think that every medic should focus on these courses also, and not only on trauma. But yeah, I think this is going to be a great course. And by the way, the tropical diseases, we should also cover some of the tropical diseases. But when we have finished, because we are also working on the new tropical travel and expeditionary medicine course, that is an online course that you can take, but it's also a 5-day course in Malta that we are running, where you get exposed for how to find out what kind of diseases, tropical diseases you have. We have a lot of microscopy, and also we go through all these normal, the major illnesses, and also the major bugs and snakes and whatever you have that is not normal in many other places.
So yeah, the next thing on the chopping block for upgrading and enhancing is the TTEMS online and tropical travel expedition medicine. So these students coming from around the world that are coming for the hands-on TTEMS can have a bit of e-learning before they arrive, or for anyone who wants the e-learning who won't be coming to a pretty big Malta, you'll still have a chance to learn the quorum way of looking at tropical diseases.
I think that's actually, I will strongly recommend that course, to do that course just for see how many things that you probably don't know about, and then you probably get encouraged to go to London School of Tropical and Hygiene Medicine, which is I think it's a 4 months course and mostly is online. So it's a great course.
So we're coming back to the whole DTN thing, and I'm kind of glad we are. It kind of wraps the bundle and makes a nice little bow tie on top of the box. The DTN program is online only, but you can supplement that, as Eirik and I both have done, by going to either Liverpool or London and do a microscopy course. So once you finish your DTN online, you get your DTN and it makes you a better medic. But until you get that hand knowledge of spending 3 days with a microscope looking at all these wee beasties under the microscope and the slides, and learning how to make slides and how to stain slides. So last summer, Eirik, that was a first for you, wasn't it? I've done these a few times, but how was it for you to have the hands-on at London?
Well, it was great. It was absolutely great, because what I was lacking from the online portion that when I did the DTN was that it was a very good course. It was very good teachers, but the thing I was sitting at home and I was looking at picture of microscopes and videos on how to make slides. But the thing is, going to London with you for the 3-day course was absolutely amazing. We were sitting from the morning to the afternoon, looking at different slides, making slides and doing samples and all that stuff. So it was absolutely a great benefit for me, and a contribution to know more about tropical diseases.
Yeah, so that slide course, I've done 3 times now. I've done once in Liverpool and twice in London, and every time I go, I learn something. So it's just, for me, having that head knowledge is lovely, of course, but until I get that into my hand knowledge, I just don't think I have it as deeply and strongly as I want to have the knowledge. So I highly suggest that anyone who wants to better themselves as a medic will first do the DT, but then, yeah, talk to me or talk to Eirik about the microscopy course.
Yeah, because just learning how to use the microscope it's not depending on the microscope you have. We in Malta, we use the small ones, the portable ones, but if you have access to the big ones, it's very nice to know how to turn it on, how to adjust it, and how to get the best image of it, and how to actually look at the slide. How are you maneuvering the slide in the microscope, and knowing where you're at, and how to actually investigate the things that you're looking at.
In Malta, we have the Newton microscope, which gets you about 900x, is made in Japan and made in England. It's okay. And most microscopists will refuse to acknowledge anything under 1000x, because that's when you go and use oil immersion. But we use them in a classroom, and you can differentiate malaria. And you can see, of course, the helminths swimming around in the blood. We train on those because that's what you're going to have in the field. You're not going to bring a huge desktop microscope into a jungle ICU. So that is, and we use the smartphone ones as well, but those only go up to 400x. But so we've deviated a bit, Eirik, from our concept of McMech and Pharm, going
Oh yeah,
into a passion of Trop Med, which does fall under DNBI. I get it.
yeah. Sorry for that.
Yeah. We're so
It's a passion.
It is definitely a passion. So I encourage you to see the new APC, the Austere Primary Care module that we have up and running on our website, or you can purchase the MIC, MEC, and Pharm individually and you still get some really good learning. But if you want the full package, the APC is now live, and I look forward to hearing the feedback from people going through it, because in 4 or 5 years, we're going to read those and improve what we've just created.
Absolutely. And if there's any questions, just to reach out to the Pharm website and we will answer any of your questions.
Yeah, we look forward to seeing how you like the new program, and we'll see you next week.
Thank you.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.